All right, today we're going to talk about anesthesia management of pediatric surgery patients. This module is, or this lecture is broken up into three different modules. This is the first of the three. Content we're going to discuss here is anesthesia setup for pediatric patients and kind of some variations. One of the big things that you run into with pediatric patients is going over a lot of their congenital defects and how they affect operative management of patients, and then common adverse effects while managing pediatric patients. So between the three modules, this is what we're going to discuss: pediatric airways, setups, those sorts of things, congenital diaphragmatic hernias, T fistulas, pyloric stenosis, gastroschisis, omphalocele, myelodysplasias, including spinal bifida and spinal bifida occulta, aperta, including meningoceal and myelomeningoceal, neurostuff, Arnold-Chiari malformation, encephalocele, craniofacial reconstruction, a variety of different syndromes, and ultimately scoliosis. First module, we're going to discuss pediatric airways, CDH, T, fistula, pyloric stenosis, gastroschisis, and omphalocele. There is a lot of board information that's covered in these lectures, so pay close attention to these. And again, things I would pay attention to are exceptions because there's a lot of commonalities between these syndromes. So when you're studying things, I would make sure I knew the differences, but also focus kind of on those differences because there are so many commonalities. So pediatric anesthesia setup varies a little bit from one facility to another, but there are some commonalities, as I mentioned. Big things that you'll see: availability of succinylcholine. Oftentimes, for pediatric patients, especially at pediatric specific facilities, they will provide you with a pre-filled syringe with succinylcholine. Outside of that location, a lot of times you're left with making sure you have a syringe, an IM needle, and the succinylcholine available. If you're drawing it up for every case, it becomes kind of wasteful. So a lot of facilities have taken the kind of position to go ahead and have it available in a pre-filled syringe. Other things, atropine is commonly given in conjunction with succinylcholine. Part of this is out of necessity. Part of this is out of the reality that oftentimes pediatric patients, when they get to the point of needing succinylcholine IM, have had a period of hypoxia, which has resulted in bradycardia. Administration of succinylcholine and DL tends to reduce your heart rate even further. So atropine is somewhat beneficial, but in reality, most of these patients just need oxygen to fix their bradycardia. The only time I've ever seen bradycardia and ultimately asystole with succinylcholine was with multiple doses. Lidocaine is common for pediatric patients as well as adult patients. Epinephrine is generally our go-to vasopressor for pediatric patients. Remember your small doses for that. It is also oftentimes available in pre-filled syringes for pediatric facilities. Another thing, make sure you have IM needles available, and generally a couple of them, because if you think about the kind of the flow for pediatric patients, usually you're doing a mask induction, maybe you can't get an airway, and you wind up having to give your paralytic IM. That way you don't have to worry about drawing up and getting IV access when you can go ahead and give it with your IM needle. For the pediatric anesthesia setup, some places have age-specific trays. Oftentimes, it's just commonly divided up for pediatric cards versus adult cards if you're in a diverse facility. You can use a large handle, you can use a small handle. For the most part, the handle shouldn't be going into the patient's mouth so it doesn't affect things. Personally, I find by using the smaller handle that I'm kind of reminded to be a little bit more gentle. But kids are kind of soft and pliable, so it's not the end of the world if you have to use a bigger handle. ET tube with or without a stylet. Personally, I don't use stylets on my pediatric patients, but there are plenty of places that do. And oftentimes you'll find that pediatric tubes come pre-styleted because there is so much variability between size for the different stylets. Just a note on pediatric airways. Generally, pediatric patients do not have difficult airways as long as they're normal patients. So when you see kids with syndromes and those sorts of things, they tend to be a little bit more difficult. Pediatric specific mask that's appropriate for that size patient. Oftentimes, I will take this out to pre-op with me and verify size. Usually, I just give it to the kid and let them play with it. That way, that I know it fits. Hopefully, I can get them to hold it up on their face. I'll say, put the pilot mask up there, and that way they can kind of experience it. But at the same time, I'm really verifying that that's the appropriate size mask for that patient. Other monitoring devices, temperature probe, whether it's nasal, esophageal, what have you. Remember, pediatric mouths and airways tend to be a little bit smaller, so you do tend to lose a little bit of space there. Suction catheters, traditional large Yankauers may not be small enough for many patients, so you'll see that often we use flexible suction catheters. And the basic things, kids need to stay warm. We use underbody bear huggers a lot more for pediatric patients because there's not quite as much real estate to do something like an upper body. So underbodies tend to work very well for them. Donut, remember there's multiple different sizes of donuts. So if you use a traditional size donut for a pediatric patient, it's going to include the airway. And then a pre-made IV kit, so that way you're good to go when you mask your kid down and go ahead and start your IV. Pediatric airways are a little bit different. Things that you run into, infants tend to be have kind of flexible, highly compliant tracheas. As a result of that, they're somewhat prone to collapse, especially if they lose airway support. So not that PEEP's not important in adults, but we tend to forget about it in children. Remember, it's also important from them. Other things you encounter, they tend to lose muscle tone and keep muscle tone gone longer with administration of muscle relaxants, especially at the hypopharynx. So know that that's kind of a key place for patients to obstruct. We're going to talk a little bit about Pacel's law. The big thing you have to remember is that resistance is inversely related to radius to the fourth power. Discussing laminar flow. Code describes the child airway when they're kind of crying in distress as turbulent, which makes sense. And that's why the text says there's even greater number for that. Laryngospasms are a little bit different from voluntary glottic closure. So if you think about it, when you're drinking, your glottis voluntarily closes. When you laryngospasm, you're taking a breath in without any sort of muscle contraction, which closes that larynx. And now you're unable to phonate, but you're also unable to exchange air. So a little bit different than voluntary. The important thing for us to remember for laryngospasms is identification early on and how to treat them. We get in this habit of thinking that because I see the chest or the abdomen moving, that the patient's breathing. Oftentimes, that's not the case. You'll see that if somebody's choking or having a laryngospasm, that they're still trying to breathe. So you see that movement of the chest and abdomen, but they're not actually exchanging any air. So the comfort of seeing physical motion doesn't necessarily mean the patient's breathing. So get out of the habit of thinking that, and that carries over to adults as well. So how do we treat it? Initial treatment, 100% oxygen if it's not already in place. Stop the stimulation. Sometimes we see that the stimulation is what induced laryngospasm. So maybe the patient wasn't adequately anesthetized when they were stimulated. So make sure that we stop whatever's going on. You may see this occurs on wake up or induction. Get help. We never want to be the only one at a bad anesthesia party, so always get help coming. Position the patient appropriately. Do what you can to open the airway, whether it's a jaw thrust, chin lift. Deepen the anesthetic. At the same time, you want to make sure that you're applying positive pressure. If you have an IV in place, that's great. If not, go ahead and, as I said, deepen your anesthetic. You may need to visualize the airway, so actually DLing the patient if possible to see that there's not some sort of mechanical obstruction in the patient. On induction, think about things like gum that could have gotten in the way. It may just be secretions. You may need to aggressively suction the patient, and then ultimately treat the persistent laryngospasm with succinylcholine and atropine. But most of the time, these are going to resolve with positive pressure or Larson's maneuver. During the case, if the patient develops a bronchospasm, not laryngospasm, bronchospasm, can be a little bit difficult to understand. Generally, when this happens, it's due to some existing history of respiratory pathology. Oftentimes, it's asthma. It may be underlying, and it may be minor that wasn't mentioned to us. So most of us will go ahead and prophylactically treat any of our patients with mild to moderate to severe asthma with albuterol preoperatively, but sometimes we don't know about it. Other things you'll see that tend to trigger these asthma events, stress, like going to surgery. Um, in pediatric patients, they tend to be a little bit more susceptible to kind of seasonal things like cough, cold, runny nose that we may not know about. Allergies are another big role. As far as management at that point, the big thing is identification. And then after that, start trying to figure out how you're going to address this patient. So these are all some symptoms that you may see as far as patients experiencing bronchospasm. Sometimes it's hard to differentiate bronchospasm from other things that are going on with the patient. Your initial indication under anesthesia may be that you see the patient's desaturating. Are they desaturating because of the FiO2 you have the patient set on? Or maybe they're becoming tachycardic. Is it tachycardia due to stimulation? If you look at your flow loops on the ventilator, you may be able to identify that there is some increased resistance. You will obviously see increased peak airway pressures. As far as the differential there, are their peak airway pressures elevated because of pain? Are they elevated because the neuromuscular blocking agent is worn off? So kind of difficult to figure out what's going on there. You may also see that there's an increase in CO2 because they're not able to adequately ventilate, and then ultimately a decrease in SpO2. But the increased CO2 tends to come before the decrease in SpO2. This is what your end-tidal CO2 waveform is going to look like. Kind of think about that shark waveform that you see oftentimes with COPD patients. Um, it may also be due to your ventilator settings. So just be careful as far as what you've set on your ventilator and know what your baseline is. So when you do have a change, you're aware and able to identify it. So treatment for these patients, as I said, deepening your anesthetic agent. So ketamine, propofol, either one is acceptable. If you have a patient with a reactive airway, oftentimes in addition to prophylactically treating them with with albuterol, we'll go ahead and administer agents that are beneficial. One of the big ones that tend to overlook for a long time was ketamine. Low dose ketamine is obviously a pretty potent analgesic, but it's also a great bronchodilator, as are our volatile anesthetics. Sevoflurane tends to be our go-to agent for pediatric patients because it's less irritating. Isoflurane is certainly acceptable as well. If you utilize desflurane in these patients, it increases airway resistance. It also alone will cause coughing, so we tend to avoid it in pediatric patients anyways. But certainly if you have somebody that's prone to bronchospasm or has a reactive airway, I would avoid it. Kind of goes without saying, but 100% oxygen needs to be administered to your patient that's becoming hypoxic. Deepen your anesthetic, as I said. Go ahead and if you have IV access, give that. But generally, these things are happening simultaneously. So you may give additional propofol at the same time as deepening your volatile agent. If they're bronchospasming, try to leave the airway alone for a couple minutes. Don't manipulate them. One of the things that we tend to get ourselves in trouble with that may precipitate the bronchospasm is suction of the endotracheal tube in a patient that's inadequately sedated. So leave the airway alone for a couple of minutes. Other things to think about that may be the trigger or may just worsen the situation. Remove whatever the stimulus is, whether the patient wasn't adequately anesthetized and then we stimulated them, asked the surgeon to stop. We're deepening the anesthetic. We can go ahead and administer inhaled beta agonist. We'll talk about it in a little bit, but make sure you know how to adapt your albuterol or any of your other MDIs to your circuit. Turning your FiO2 up, decreasing your PEEP transiently if you have a high PEEP to minimize your air trapping. But at the same time, our overall goal there is to temporarily reduce the airway pressure. So just make sure you're kind of aware of what their baseline airway pressure is, because that may be the first clue as they start to bronchospasm, is you do see those airway pressures go up. Treatment may need to utilize IV steroids, which takes some time to work, but may reduce the long-term incidence of bronchospasm. If you have somebody that has severely reactive airways, I would consider administering the steroids early on. but you kind of have to see what's going on with the patient. And oftentimes that's learned with experience because many patients don't require steroids, but there's certainly some that do. And developing that threshold takes some time. And here's the doses for you for epinephrine. It's a little bit different than your code dose, zero point zero 0.05 to zero point 0.5 mics per kg. And you may repeat it as often as every minute. Remember, it works very fast. So if it's not working, you may need to give more. So one of the issues we run into, especially when you guys are in residency, as you're rotating from one facility to another, is how to adapt your beta agonist or your MDIs to your patients. We may be able to utilize a traditional nebulizer with our ventilator circuit, but oftentimes what we utilize is one of these MDI adapters. The thing that doesn't quite permeate to everyone, MDIs actually do a little bit better job of delivering the medication than a traditional nebulizer. And the reason for that is the MDIs provide a very fine mist of the medication, whereas the particles from a traditional nebulizer are actually quite large. So the MDI tends to get a little bit further into the airway than the traditional nebulizer does. So this is one example of an adapter, and I'm going to show you a couple others here to kind of look at. But this is pretty straightforward. Just make sure you do put it in line the way it's supposed to be. Almost all of these just utilize a 15 to 22 adapter system with the port. Some of them have a little channel for your MDI to fit into, some don't. So just know what your facility has. There are some improvised setups we'll talk about in just a second as well. So one of the things that we do if we are going to utilize a traditional nebulizer is getting all our equipment. On the left side there, you have basically what you find in the kit. So you've got your oxygen or air delivery tubing, your nebulizer chamber, and then the T-piece. Other things that have been added kind of into this kit, because the problem you run into when you start utilizing the nebulizer, our endotracheal tubes are generally vertically coming out of our patients. So if I hook up a nebulizer at that angle, it tends to not aerate very well and dump a lot of the fluid. So you can use one of those flexible trach adapters that lets you kind of turn your nebulizer to the side. Other things you can do, and again, the biggest thing is having all the pieces and parts as far as utilizing this, and I'll show you a little picture of it kind of in action here. So that's what it would look like going into your patient. Again, use that flexible tubing so you're not dumping all the albuterol down your endotracheal tube. Other things you can do as far as going back to the MDI, you can use a 20 ml syringe or a 30 ml syringe, depending on the size of your MDI, and just take the medication chamber itself out and put it inside that syringe. Because of the tapered part of the syringe, it'll fall down there. And then you can screw it onto the lower lock adapter that you see here with the blue cap on it and administer it that way. Another method I see, which is probably not quite as effective, is just taking the circuit off of the patient, holding the MDI over the end of the endotracheal tube and spraying it several times. All of those work. Some obviously work better than others. One just caution for you, if you are using put the MDI over the end of the endotracheal tube, be cautious because it tends to make it very difficult to disconnect your circuit. It almost creates like a stickiness right there between your endotracheal tube and your circuit. So just be cautious with that. And again, one of the biggest things here is just making sure you have the pieces and parts ahead of time. Some facilities have pre-made kits, others have to improvise. One of the issues we run into from time to time is figuring out whether our patient's having a laryngospasm or a bronchospasm. Obviously, if your patient has an endotracheal tube in place, you're not going to notice the signs and symptoms of a laryngospasm. So that kind of helps with clearing up the diagnosis there. Issues you run into and kind of differentiating the two. Laryngospasm tends to be an inspiratory condition, whereas bronchospasm, they tend to not be able to exhale, so they have a whole lot of air trapping. With laryngospasm, you'll have stridor. Bronchospasm, you tend to have wheezing or croup. With that being said, you can still have a hard time or hear stridor on expiration with patients with a bronchospasm. So ultimately, it may be a little bit hard to differentiate the two, but these are just kind of some helpful tips for you. When you look at the patients, if they have a laryngospasm, you'll see that there's intercostal as well as subcostal substernal retraction. Uh, Whereas bronchospasm, you tend to see that they're having difficulty with accessory muscles, and that's where you tend to have the retractions. Laryngospasm, there's not really any change in expiration because there's not any air movement. Um, so obviously, if you have a patient that has laryngospasm and they're able to expire, you may actually be breaking that expiration. I've seen more than one patient have their laryngospasm broken by pressure applied to the chest, which forces the air out of the lungs through the vocal cords. Patients with laryngospasm, with bronchospasm, tend to have a prolonged expiratory phase because they're not able to exchange air very well due to that trapping. Laryngospasm tends to be a very fast onset, whereas bronchospasm tends to be a little bit slower condition. Other conditions we encounter post extubation croup. Patients post surgery are a little bit more prone to develop croup, um, especially if they have an existing history of croup. So things that you'll encounter for whatever reason, whether it's surgical stress, uh, inflammation from anesthesia, for some reason they wind up with inflammation and edema of the tracheal mucosa. As a result of that, you see kind of circumferential reduction in the luminal diameter and obviously increased airway resistance. At this point, airway resistance is inversely related to radius to the fifth power. Remember, we talked about the differential earlier. So patients with post-extubation croup, not entirely common, but you do see it in up to 1% of children. Risk factors that may result in it. We discussed a previous history of croup, but larger ET2 size than normally utilized. Changes in the patient position other than supine. So think about patients that would have any sort of increased fluid or oncotic pressure on their trachea. So somebody standing on their head, somebody being prone. Um, Kind of traumatic intubation and or any sort of increased stimulation of the airway as they're being intubated. Obviously, anything that would cause edema is increasing your risk for post-procedure croup. Younger patients tend to be at a little bit higher risk. Obviously, they're the ones with the smaller airways as well. And then procedures that are a little bit longer tend to be problematic. Treatment, primary treatment is nebulized epinephrine. Um, Steroids are beneficial. If you have somebody with a strong history of croup, I would consider utilizing steroids in advance, although oftentimes I utilize steroids for all my patients anyways. Other things that are beneficial, moist humidification for these patients. When I was in paramedic school, the medical director at the time said, one of the best treatments for these patients is really just to drive around in a moist, cool, humid environment. So he would tell parents to just put the kid in the car, drive around with the windows down. Doesn't work if you're in the middle of the desert, but you'll see that many of these patients will have a humidifier at home and they may actually have a nebulizer that they just utilize sterile water or saline in to provide that moist humidification. Other things that tend to help using a microcuff ET tube provides a little bit more uniform surface contact, so it reduces the risk for some of those patients. All right, so we're going to transition from kind of some of the overall stuff to some of the specific disease processes you encounter. The first one, and probably one of the more common ones that you'll see on boards, is congenital diaphragmatic hernia. And this picture provides a lot of information for you. We'll talk about it a little bit more in detail. Um, but you'll also see this occurs with adult patients as well, not the congenital version, but traumatic diaphragmatic hernia. And all that's going on in these patients is that the intestines have herniated or made their way up into the chest cavity. As a result of that, you can see there's mechanical compression of the heart as well as the lungs. So, not extremely common, but 1 in 2,000 live births is common enough to make me worry about it, especially if you're potentially considering becoming a parent. Why does it occur? For some reason, there is incomplete closure of the pleural and peritoneal canals. So your abdominal contents are going to herniate up into the thorax, as I said. What you see in the pediatric patients that's a little bit different than when we think about CDH in adult patients is that as a result of this, in utero, you have a delay in normal lung growth. So everything from airway formation and development into the pulmonary vasculature. So it's not just a matter of fixing the mechanical issue. They also have time that they have to compensate for because they haven't had adequate growth. Whereas adult patients have had adequate growth, they just have this brief insult as a result of the herniation. What you see in these patients because of mechanical compression is they have decreased surface area for gas exchange that results in increased pulmonary vascular resistance and primary pulmonary hypertension. Uh, Usually, what you'll see is that the ipsilateral lung is the one that's most affected, but the contralateral lung can obviously be affected as well, depending on the volume of gastric contents that have herniated into the chest. This is a common test answer. The most common location for congenital diaphragmatic hernia is the posterior lateral foramen of Bachladaek. It's usually on the left side and accounts for about 90% of congenital diaphragmatic hernias. It's also associated with the largest extrusion of gastric contents into the chest and is associated with pulmonary hypoplasia. It's 5 times more likely to occur on the left side of the chest versus the right. These infants tend to be more likely to have other birth defects as well. So you'll see in pediatric patients in a lot of these syndromes that it's oftentimes not one syndrome, but it's multiple syndromes. So that's why I was saying early on that it's beneficial for you guys to learn the exceptions versus trying to learn all the individual statistics for each one. 2% of these patients will have a Morgani type defect, whereas the rest occur through the esophageal hiatus. So those common defects are those common associated syndromes you'll see, malformations of the GU and GI systems, as well as chromosomal abnormalities, the most common being trisomy 13, 18, 21, and 12p psychism. So this is a little blurry, but this is kind of a picture of where you tend to see these herniations occur. So Bachladaek, as I said, tends to be the most common, with the most common out of those to be about left-sided and posterior lateral. So we tend to think about these occurring anterior, but a lot of times these are herniating a lot more posterior than we think about. When you see these on x-ray or on film, the reason it looks like it's anterior is because there's just that much volume in the chest at this point. But it's actually occurring through the posterior entry. So left is the most common, right second most common, and then you do have some occurrence anterior through the foramen of Morgani, but it tends to be a lot less. You will also see there are some patients that do not have a diaphragm and can herniate through there as well, but that tends to be a lot less common. So how do we diagnose this? Um, Most commonly, if you have somebody that's received prenatal care, they'll be able to make the diagnosis on ultrasound. Unfortunately, many of these patients don't receive prenatal care, which already puts them at high risk. But when they start looking with the ultrasound, what they'll see is that they have polyhydramnios, a large intrathoracic gastric bubble. Usually our stomach isn't in our chest, so if it is, that's kind of a clue. And then when they look at the mediastinum, they're able to see that there's a shift away from the herniation site, which makes sense. Your lungs are displacing all that intrathoracic volume to the other side. After birth, you can make diagnosis via chest x-ray, and all you're going to see is just that there's intestinal contents or abdominal organs in the thorax, and then compression of the ipsilateral lung. One thing to be cautious with these patients is recognizing the incidence of diaphragmatic hernia versus pneumothorax. Oftentimes, when we look at a chest X-ray, we may not realize that that lung compression is being caused by gastric contents versus a pneumothorax, especially if you have large loops of air-filled bowel. That can make it a little bit harder to see. And one of the things we do that tends to make that worse, baby's born, baby has pulmonary issues, they wind up getting oxygenated, eventually being ventilated, and you will see that sometimes that air gets forced all the way down into the bowels, which makes things a little bit worse for us. Just another picture here for you, kind of showing a normal child versus one with a congenital diaphragmatic hernia. And in these lectures, there's a lot of pictures to kind of illustrate things. Part of that is because you will see in real life as well as in boards that you see a patient, and based off of that, you may have to start thinking that there's something strange here. So if you develop that memory of this is kind of an abnormal presentation, it's helpful for you. Again, just different pictures. If you look up here on the right, you can see a transvaginal scan that kind of shows you what you're looking at. I am nowhere near proficient enough with an ultrasound, especially on anything transvaginal, to identify this. You'll see a lot of times patients that are screened by their obstetrician where they recognize that there's some sort of abnormal pathology are then referred to maternal fetal medicine or high risk center. More commonly, what you'll see is this picture down on the bottom right with a chest x-ray that shows herniated gastric contents into the chest. That's pretty easy for any of us to recognize. But you kind of see here the traditional bowel picture, but at the same time, you also see that that bowel is pretty full of air. So it may be a little bit harder to recognize exactly what's going on other than the fact that the lung's been displaced. Signs and symptoms for these patients, obviously, they're having a little bit of difficulty breathing because they've lost half their lung volume. As a result of that, they tend to become tachypnic, they're tachycardic. You will see that they are usually cyanotic at birth, which may make the identification or diagnosis a little bit harder as a result of a right to left shunt, which tends to make them severely hypoxemic. When you look at their abdomen, you may see that it's concave or kind of indented because there's no longer gastric contents in there. So, when you palpate the abdomen, it may feel empty because it basically is. When you look at the chest, because of the presence of gastric contents in the chest and the pliability of pediatric patients, they may have a little bit of a barrel chest, especially on the side that has had the herniated gastric contents. And then you may have absent breath sounds on the affected side and may indeed have bowel sounds on that side. But because of the limited amount of real estate in pediatric patients, you may see that it's difficult to identify that. So how do we treat it? Your overall goal is to get the patient surgically corrected, but how do you do that, especially if you're not at a pediatric surgical center? So what we're usually going to focus on is initial medical stabilization and optimizing the infant prior to surgery. So how do we do that? Trying to treat their pulmonary hypertension and decreasing their pulmonary vascular resistance. So one of the kind of go-tos oftentimes for these patients will be mechanical ventilation, usually utilizing an oscillatory ventilator. And the reason for that is that you deliver small tidal volumes with limited peak airway pressures. And we try and avoid CPAP because as we utilize CPAP, it tends to force more air into the chest cavity. And as a result of that, you have those high airway pressures. So that's one of the big reasons we utilize oscillatory ventilators for those patients. Again, how often are those available, especially in kind of outlying facilities? Other things that may be beneficial for these patients, utilizing vasodilator therapies. Many times we'll put these patients on inhaled nitric oxide, as well as utilizing prostaglandin E1s to keep the PDA patent and reduce the right ventricular afterload. In severe cases, ECMO may be utilized, but again, you have to think about what facilities have ECMO available to them. What you sometimes see is that these patients will be met at the bedside by an ECMO team, cannulated, and then taken back. But again, depends on your location. The other thing you will see is these patients tend to have specialized transport teams that will pick them up at the outlying facility and then take them back because a lot of these specialized therapies may not be available. Things like inhaled nitric, PGE1s, those sorts of things. This is just a view of what it looks like when they go through and repair. Oftentimes, they'll close the diaphragm and they'll also kind of use the omentum as a secondary patch for these patients. So when we start thinking about things that are kind of problematic after that initial period, pulmonary hypertension is really the biggest cause of morbidity and mortality in these patients if they don't go on ECMO. So what we try to do is, again, focus on things that reduce that pulmonary hypertension in the short term. So nitric oxide is a big one, as is PGE1 medications. This is an open surgical procedure done through the abdomen. Oftentimes what you'll see is that because the child has developed without having those gastric contents in place, the abdomen is too small to accommodate everything being placed back in there. As a result of that, when it gets put in there, you see that the diaphragm is forced upwards, which was one, just freshly repaired, so you're trying not to have pressure on it. But it tends to result in a pretty significant decrease in your pulmonary compliance because of mechanical compression. So when that happens, you all basically have to do a staged repair. So unable to put all the gastric contents back into the abdomen, we'll utilize a silo-low or silo-elastic pouch, which is basically like putting a cocoon over top of the viscera. And then we're slowly going to replace the gastric contents into the patient. You may also see that a chest tube may be utilized on the contralateral side to help reduce intrathoracic pressure, because pneumothorax is pretty common. You may also see, if the patients are stable, that a thoracoscope is utilized, but my personal experience has been that this is more often done as a open gastric procedure. If they're pretty stable, we tend to not have to deal with a lot of these issues, but you can also do it as a one lung ventilation case. So if we're going to do this video assisted, basically what's done is the patient's placed in a lateral position. You're going to move the upper arm out of the way, similar to what you would do for a batch for an adult patient. And then you're going to ventilate these patients in kind of a little bit different setup than what we do for adults. Instead of isolating the lung, a lot of times what we'll do is lower tidal volumes and lower pressures on the CO2 insufflation, and that helps us guide everything back into the abdomen. We know that if we're able to do it video assisted, it's better for the patient's prognosis long term, but oftentimes, as I was saying, those patients are a little bit too sick to tolerate the thoracic procedure, and it has to be done open. Things for us to think about as far as anesthesia management of these patients: avoiding volume trauma. So they may remain on the oscillatory ventilator. Our anesthesia ventilators aren't appropriate for many of these patients, so consider taking the oscillating vent to the operating room. That may involve taking a respiratory therapist to the operating room as well, because we're not comfortable or experienced managing those ventilators. Things we can do to kind of benefit the patient intraoperatively: avoiding increases in PVR, so things like hypoxemia, acidosis, hypothermia, and hypercarbia. In an effort to decrease the PVR, we may be able to hyperventilate the patient, do things that will help reduce the big sympathetic stimulation. So opioids tend to be a go-to, as well as muscle relaxation. And if these patients don't already have an NG tube in place, you need to go ahead and do it, because there is an increased incidence of air going into the stomach, which will ultimately make its way further into the bowels. And as that happens, you're going to have increased pressure in the thorax, because you've just insufflated the stomach that's now compressing the lungs. So NG tubes are definitely a go-to for these patients. Other things to think about: avoiding nitrous oxide. Obviously, it's going to result in hypoxia in addition to causing problems for you. These patients will stay relaxed during the procedure. So commonly what you'll see is that a combination of two things that are used: muscular paralysis as well as opioids. So most commonly fentanyl and vacuronium, rocuronium. Induction of the patients, commonly done with high doses of opioids and muscular relaxants. Usually these patients will go back to the ICU intubated for several days, and we will also generally keep them chemically relaxed as well to allow for recovery. So we're going to transition from CDH to TE fistulas, and this is just an example of the different TE fistulas you will see. I will tell you that this is a common picture that pops up on boards. So the first one, what you're seeing is that the trachea is isolated from the esophagus. The esophagus ends in a blind pouch. So That's not the most common one you'll see. The second one, you have a fistula between the trachea and the esophagus. This tends to be fairly common. The next one, you have an esophagus that ends in a blind pouch, but the distal esophagus has a connection to the trachea. The fourth one, you just have a blind pouch with no distal connection. And then in the last one, you have a parallel connection between the trachea and the esophagus. So a little less common than CDH, 1 in 3,000 births versus 1 in 2,000. Most of these patients have esophageal atresia with a distal esophageal pouch and a proximal tracheoesophageal fistula. Usually it's located 1 to 2 centimeters above 1 to 2 tracheal rings above the carina. It tends to affect males and females equally, and there doesn't seem to be any sort of racial disparity for these patients. It occurs very on in gestation, so 4th or 5th week, and occurs as a result of separation of the trachea from the foregut. It very commonly is associated with Bacterial. We'll talk about that in just a minute. So what is Bacterial? This is generally a good way to remember the syndromes that are associated with these patients. So they tend to have an increased incidence of vertebral anomalies. There's an imperforate anus. They tend to have congenital heart diseases, TE fistula, obviously, renal issues, as well as lib abnormalities. So we're going to go a little bit further into some of those. So how do we diagnose TE fistula? Usually it's diagnosed on ultrasound during gestation, polyhydramnios, a small or absent gastric bubble, a blind ending upper pouch, and the fetal neck. So if you think back to the symptoms that we saw in patients with CDH on ultrasound, they tend to have that large gastric bubble that's in the chest as opposed to having a smaller absent gastric bubble. After birth, symptoms you'll see in these patients: excessive salivation, choking, coughing. Remember, they're not able to swallow their secretions because they do have that basically either blind pouch or secretions that are going directly into the trachea. So as a result of that, they're not able to manage those. At their initial feeding, you'll see that they tend to cough and sputter, leading to cyanosis as those contents are regurgitated into the trachea. Respiratory distress as a result of that, and then the abdomen starts to become distended with air as the baby cries, because remember, you've got that connection from the trachea into the esophagus into the gastric. So as a result of that, anytime they're breathing, especially if there's increased work of breathing, you're going to have a large amount of air that's going into the stomach. If you try to pass a gastric tube, you will oftentimes see that it either hits that blind pouch and stops, or that you start losing tracheal volumes because it's passing down from the esophagus into the trachea. Think about when you accidentally put an OG or an NG tube into your patient's trachea post-intubation. Same sort of thing. You're going to see collapse of bellows, that sort of thing. You'll probably see this again, the 3 C's for TE fistula. So choking, coughing, and cyanosis are a nice little mnemonic for you to remember. How's it diagnosed? As I said, you're unable to pass the nasogastric tube into the stomach. You may wind up passing that nasogastric tube into the trachea. If you get any sort of imaging, you'll see that the proximal esophagus tends to be dilated with air. And then when you look at the stomach, there's large amounts of air. Or you may do an endoscopy or bronchoscopy and actually follow this down into the patient. But those tend to be done a little bit later as kind of confirmation. You may also do a CT that provides a little bit more imaging for you. We tend to do CTs a little bit more commonly than MRIs for these patients. So this is an example of a chest x-ray in a patient with TE fistula. As you can see, the gastric tube is going down, looping, and coiling, as well as having a large amount of air down in the gastric bubble because of the connection to the trachea. There are other reasons this could happen, but this is kind of one of those things that makes you start to think that perhaps there is a TE fistula. So goals for these patients pre-procedure: trying to do whatever you can to eliminate the retained products inside the proximal pouch. So usually that's going to be NG tube placed to continuous suction. We try to avoid mask ventilating these patients because the air is not going to go into the lungs. It's just going to wind up increasing the gastric distension. So think about almost like an RSI type picture for these patients. Uh, and inhalation induction is less than desirable, but oftentimes these patients already have IV access. Again, like with CDH, we try and focus on stabilizing the infant prior to surgery. So, how do we do the surgical repair? It's usually done either via an open thoracotomy or a video assisted thoracotomy. Um, Oftentimes now we're seeing that more and more patients are having video assisted done. Uh, Placed in a left lateral recumbent position, right thoracotomy. That way we avoid the aortic arch that tends to be pretty uh, large on the left side. Excuse me. Yeah, left side. Uh, Again, we don't have to utilize single lung ventilation as long as you're able to oftentimes utilize like an oscillatory approach. If you've taken a nasogastric tube that's actually going down into the esophagus, it may be helpful for the surgeon as he's palpating things to identify that proximal pouch. So first thing you do is ligate the fistula, so you no longer have communication between the trachea and the esophagus. And then after that, they just go through and do an anastomosis of the esophagus to the distal pouch. Um, and we talked about this being for pediatric patients, but I've seen more than one adult patient have a TE fistula as well. Commonly, from our end, it's as a result of something eroding through the trachea into the esophagus. Things to consider for these patients: keep the infant spontaneously breathing to avoid positive pressure. That way, you don't have all that air introduced into the stomach. It can be very difficult for that, but as I said, a lot of times these patients will already have IV access. That helps out a little bit. Um, but if they are crying, you may see that you wind up a lot more air introduced into the stomach. IV induction, as I said, is preferable and tends to reduce the incidence of air trapping. If you do have to mass ventilate these patients, use low peak airway pressures. And you're going to take the endotracheal tube and put it above the carina, but distal to the fistula. So that way, while you're mechanically ventilating the patient, you don't have increased incidence of air being instilled into the gastrum. And this is just kind of what I'm talking about there. So you see your fistula there on the left side. The endotracheal tube is distal to the fistula. So you're able to ventilate both sides without having air going into it. Other things that can be done, you can use a balloon catheter to occlude the different locations, but most commonly we just advance the endotracheal tube down to the carina and ventilate. Considerations from an anesthesia standpoint, um, you may have to frequently suction these patients into tracheal tube because of the large amount of secretions they've retained. After surgical correction, we tend to ventilate these patients with an increased IE time to allow re-expansion of the alveoli. Remember, they've been adequately ventilated for quite some time. If we're able to provide these patients with early extubation, it tends to help alleviate pressure on the suture lines. However, oftentimes to allow the patient to rest and help prevent pneumonia from retained secretions, we'll keep these patients intubated for some time. Um, if you're able to keep the endotracheal tube in place, it allows you to continue to expand the lungs as well as suction retained gastric contents or secretions. We try to keep the patient in kind of a neutral position to avoid putting any sort of tension on the anastomosis inside the esophagus. Um, we will oftentimes place an epidural catheter from the caudal space, provide a little bit of analgesia for the patient. All right, we're going to move on to pyloric stenosis, which is far more common than any of the other two defects that we've talked about so far, 1 in 500 live births. It's more frequently found in firstborn males, 4-to-1 ratio. And it's usually diagnosed between 2 and 8 weeks of age. What you'll see is these patients tend to have kind of non-bilious vomiting after feeding. Um, and if you've spent any time around kids, you know they tend to erupt whenever they feel like it, anyways. But this tends to be a constant thing. Other things you'll see is that they're constantly upset. They tend not to put on weight, but kind of the hallmark of it is this projectile vomiting. So what happens here is that you have hypertrophy and hyperplasia of the muscular layer of the pylorus. As a result of that, you have a mechanical obstruction of the gastric outlet. So they're not able to get food down adequately. And as a result, anytime they eat, they immediately vomit it back up. Because the child's not getting adequate gastric intake, they tend to be very hungry all the time. So it makes things a little bit worse. Usually, you're able to recognize this, like I said, between 2 and 8 weeks in these patients. You tend to have a pretty significant electrolyte abnormalities as well as malnutrition. The classic kind of presentation for this is this olive-shaped mass in the right upper quadrant. So just remember that that's kind of a popular board question. So how do we treat it? Manage the nutritional needs as well as doing a pyloromyotomy. So from an electrolyte standpoint, we tend to see these patients are hypokalemic as well as hypochloremic, and then they have a metabolic alkalosis. If it's not caught and it's not managed well, you'll see that over time these patients actually progress to metabolic acidosis because they just had that significant of a volume loss. You'll see the kidneys are excreting bicarb trying to maintain a normal pH. Um, and then they're also going to start excreting hydrogen and then potassium, again, trying to correct the uvulaemia and retain sodium. So generally, this is not a real medical emergency. So the patients are going to be admitted slowly, and then we kind of start medically correcting things. It's not something that has to be rushed to the operating room. We try to stabilize them as best as possible. So we'll establish IV access, get them adequately rehydrated, and correct any nutritional needs if we're able to. One of the big things we do, in addition to volume replacement on these patients, is get dextrose going so they are getting some nutrition. Kind of your tips that this patient's ready for surgery when they have return of good skin turgor, so they've had adequate volume replacement, urine output is adequate, sodium has improved to greater than 130, potassium's been corrected, and then chloride is also corrected. So how do we diagnose this in addition to symptoms? Ultrasound is helpful, but oftentimes what you'll see is that it's done in conjunction with a barium swallow. So you'll have this kind of as confirmation. The downside is barium is not a real great thing to aspirate into your lungs. So be cautious in those patients. And you'll see that it's usually done with a very dilute amount of barium as opposed to kind of the thick sludge we see with adult patients, because we do know there's increased risk of regurgitation. Oftentimes now you'll see that it's diagnosed so quickly that it doesn't get to the point of them having these severe electrolyte abnormalities. But if you happen to be in an outlying facility or maybe an out of hospital birth, it may not be recognized quite as quickly. And this little donut sign is just that thickened pylorus. Um, so they call it the donut sign because you've got this thick olive in the middle of that air-filled space. And this is just an example of that barium swallow study. You can see the barium coming down the esophagus, and then it's pretty easy to identify the pyloric stenosis in the distal gastric. So how's it repaired? They do a pyloromyotomy. It's often done laparoscopic nowadays. We don't see very many open pyloromyotomies anymore. There's a periumbilical incision, so they look great in bathing suits later. And as a result of doing the laparoscopic repair, we tend to see that they get out of the hospital quicker. They're able to get back to oral feeding. And as I said, even though it sounds kind of silly, is that it's preferred cosmetically because of that. And this is just them doing an open pyloromyotomy. And this is what you're left with afterwards. As you can see, it's not even for an open, it's not a huge incision. Um, this is a lap pyloromyotomy. So essentially, just because of the small size of pediatric patients, you're still going to have kind of the same size incision, even though it's a little bit smaller if it's done laparoscopically. It's usually done with a single port now if you have pretty proactive surgeons. But if they do use multiple ports, they tend to use very small ports for the secondaries. Again, just another view of what you're looking at post-procedure from a laparoscopic standpoint. From an anesthesia perspective, things we need to consider: getting the airway secured quickly, because they are obviously at increased risk of regurgitation and difficulty ventilation because of the gastric outlet obstruction. Um, Other things we want to think about: large amounts of towels for these patients because they tend to vomit. So you want to make sure that you can kind of clean up things there. Um, I tend to use a red rubber catheter for these patients. I'll go ahead and just put it down and use it for gastric decompression. Um, Pre-oxygenation is obviously important. And then when we suction these patients, make sure that we kind of rotate the patient around, so we are able to evacuate any sort of gastric contents in there. This is just kind of an example of an anesthesia setup here. One of the other things you'll see is that PR Tylenol works pretty well as an analgesic for many of our pediatric patients. These are just some examples of dosages for these patients. We try to avoid narcotics if possible. One of the issues we run into with a lot of these gastric surgeries is that you have a decrease in peristalsis. They have an increase in the likelihood of having a postoperative ileus with opioids. So if we're able to avoid that, it's pretty beneficial for us, especially now that we recognize so many other medications offer analgesic properties. It's a very fast procedure. You guys can see the surgical approach and see how quickly that can be done. Oftentimes, getting the patient anesthetized and positioned is the longest part of the case. We discussed opioids. There's really not a whole lot of pain for these patients, but what we will do a lot of times is localize, especially if it's done laparoscopically. And then we're going to continue these patients with nutritional support post procedure until they're able to adequately tolerate oral intake. In the recovery room or in the operating room, depending on your facility, make sure the patient's awake for extubation because there is an increased risk of regurgitation. It is pretty common to see postoperative respiratory depression in these patients. As a result of that, it's another benefit to avoiding opioids even in the postoperative period. They need to be maintained not only on a pulse ox, but an apnea monitor for about the first 24 hours. So as a result of that, we do visit specialized pediatric centers. Uh, Keep an eye on their nutritional needs, monitor for hypoglycemia. Can be done with just finger sticks. As far as the glucose status, the rest of the labs need to be monitored, especially your chemistry panels. If you're going to use opioids, you can use them in small doses in the recovery room. But as I mentioned, we try and avoid using opioids and go in favor of other approaches for analgesia. So we're going to transition from that to gastroschisis and omphalocele. And I'll just tell you the easy way I remember this. Gastroschisis, you have no membrane that's covering the intestines. So schisis, snakes, because it looks kind of like a snake to me. Whereas omphalocele, you have the covering, so it looks like an O to me. That's the easy way I remember it. I don't know if that makes sense to everybody else, but it does to me. Occurrence of gastroschisis, about 1 in 2,000 births. And what happens is that you get occlusion of the omphallomesenteric artery during gestation. As a result of that, there tends to be a herniation of the abdominal contents outside the abdomen. One of the nice things about gastroschisis is it's usually not associated with other congenital abnormalities, which is kind of different than a lot of the syndromes we're talking about. You'll see the viscera herniates usually just around the umbilical, and it's usually on the right side. It's functionally abnormally dilated, and you'll see that there's a shortened bowel because they're exposed to the amniotic fluid in utero, and it is air as a result of that, which results in edema and inflammation. Who would have thought that amniotic fluid's not a great thing to contact your intestines? And this is just an example of what you see in somebody with gastroschisis. Omphalocele occurs in about 1 in 5,000 births, so it's a little bit less common, and it occurs as a result of the gut failing to migrate from the yolk sac into the abdomen during gestation. it is associated with a lot of abnormalities: genetic, cardiac, urologic, and metabolic. So if you're going to pick one, gastroschisis is better, even though on the surface it appears to be a little bit more disruptive. The intestines emerge from the umbilicus, and it's covered in kind of a membranous sac. Um, the bowel is usually normal. It's just not normally placed. But remember, you do have all those other associated abnormalities. And this is just an example of an omphalocele for you. Good chart to remember that kind of shows you cause, location of the defect, as well as the associated abnormalities for those patients. This is just another little thing to help you. I don't know if this is any better or worse for you. Again, another little mnemonic for you. So if you have somebody that's born with a gastroschisis or potentially even an omphalocele, you have to manage the patient transiently until they're able to get surgical repairs. One of the biggest issues we run into is that there's significant temperature and fluid loss because it's exposed to air. So we tend to put a temporary barrier over top of it. It looks like a plastic bag because it basically is. So what do? We try and maintain perfusion of the viscera so they don't have any sort of loss of intestinal function. But the big thing, like I said, is fluid and temperature loss. So initially, we're going to cover the mucosal surfaces with moist dressings, basically just something as simple as saline soaked gauze. And then we put a plastic wrap over the herniated viscera, which helps us reduce the incidence of heat loss and and volume loss. It's a lot more pronounced with gastroschisis than it is with omphalocele, which just makes sense because with omphalocele, you do have that membrane that's covering it. And then ultimately, we're going to do a surgical repair. Or if the abdomen is unable to tolerate a one-time repair, you may do a staged repair with a psilastic pouch. And all we do with that is just slowly reduce the pouch size, which encourages the intestinal contents to go back into the abdomen. And this is what that psilastic pouch looks like. It's basically a very expensive plastic bag. So how do we manage these patients? Volume loss is a big problem for both these patients. So adequate fluid resuscitation, temperature management to reduce the incidence of hypothermia. You can put an intragastric tube in, and you'll see that a lot of times what happens is that we will measure that pressure, because as you start putting the intestines back into the abdomen, if you have increased pressure, they can have abdominal compartment syndrome, just like a burn patient or a trauma patient or anybody else. So if you have increased pressure above 20, they may have to go back and do a surgical decompression. Other things you can see, the bowel can quickly become edematous, and you can have renal congestion resulting in decreased urine output, venous edema in the lower extremities, and then cyanosis as a result of the impeded venous return. So all of these are things that we will see in adult patients with abdominal compartment syndrome as well. There's just a different morphology in these pediatric patients. You may see that you have variations in perfusion between the upper and lower extremities because of the bowel distension that's causing venous return to be decreased. You'll also see that you have atelectasis in the lower lobe of the lungs and potentially respiratory failure. As that bowel becomes more and more edematous, it tends to cause compression inside the thorax. From an anesthesia standpoint, kind of basic things that we do for all our other patients: make sure the room's warm, underbody bear hugger, anything you can do to kind of capitalize on keeping the patient warm. Aspirate the gastric tube that's in place to help reduce the volume of the intestines. Good pre-oxygenation, RSI with cricoid pressure for these patients as well. Maintain with oxygen and air, avoiding nitrous because of the increased risk of bowel distension. And then again, narcotics and muscle relaxation are kind of our go-to for these patients as well. Other things to think about: maintaining adequate nutrition through dextrose containing IV fluids that will continue post-procedure. Keep an eye on your airway pressures. Oftentimes that's going to be the guide to whether or not they do an initial primary closure or if they have to have secondary closure with a psilastic pouch. So if you see those airway pressures are increasing pretty drastically, make sure you communicate that to the surgeon. because if you've had a pretty significant increase in your airway pressure, so you're not going to be able to extubate them. So generally over 2025 or a significant increase is one of the big things we will look out for. Other concerns, compression of the IVC may be indicated by hypotension. We're going to keep them hydrated intraoperatively using crystalloids. They may require colloids depending on how volume depleted they are. They may get extubated post-procedure, but oftentimes we'll keep them intubated for a day or two just to keep an eye on those airway pressures, because you do see that you have bowel edema that occurs over the next couple of days, and that may require reintubation if they've already been extubated. And that's what I've got.